All right. So today we're going to finish up thinking about the veins, and we're going to briefly mention the lymphatic system and hopefully get into our regulation of mean arterial pressure, so blood pressure. A couple notes. We're still got time before our next exam, but I had set a practice test to open this afternoon, so I'll just leave it there. I might adjust questions a little bit over the course of the next week, depending on how far we get. We have like blood listed on our schedule. Historically, we don't usually make it through the whole packet by the time the exam comes. I tried to make the schedule this year so that we can actually finish everything we said we're going to do, but stay tuned on that. But the stuff that we've covered already, you should be able to identify on that exam if you want to get studying in that manner already. Okay. Any questions about like course business and stuff at this point? We haven't had check-in in a while. Okay, cool. All right. Let's see if these questions are going to work today. No, maybe they work in my office and not here. Okay. Well, we will imagine a scenario anyway, based on what we did last time. So one of the things that we're thinking about as we're thinking about veins, right? One of the important things is that our veins returns our blood to the heart. So here we've got an example of a patient. This patient has something called chronic venous insufficiency. Their experience of this means that they end up with like a lot of swelling in their legs, especially when they're standing. So the type of recommendation you might see in a situation like this is you might go to the doctor and you might get recommendations to like flex your ankle throughout the day to help with this symptom. If the questions were working, you would tell me how these exercises might be helping the patient's symptoms. So I'll give you a second to whisper to your neighbor. What are we doing with this? All right. So last time we were talking about our different types of pumps that help us adjust our venous system and help that return to the heart. So this would be activating that skeletal muscle pump, right? So using the muscles in your leg and ankle to kind of create pressure in the ankle, push blood back up into the calf, and then on its way back to the heart to help you fight gravity if those veins are particularly kind of loose there. So last time we talked about two types of pumps, right? So we talked about the skeletal muscle pump, so using muscles to create these pressure gradients in the veins, help you fight gravity back towards the heart. And we talked about the respiratory pump, which involves understanding how pressures in the thorax and the abdomen change a little bit as you breathe, but the same sort of situation, creating a pressure gradient in the veins, which usually are supposed to be under low pressure, right? But we can make veins in the chest under particularly low pressure as we breathe in, sucking blood towards them and pushing blood from the abdomen, which is higher pressure at that point, helping blood return back to the heart. So we left off thinking about this concept of venomotor tone, which is a little different, right? So both of those other two factors influencing venous return, so just blood in the veins returning to the heart, have to do with kind of like more physicsy concepts, right? At least we're thinking of them as pumps directly affecting our pressure gradients. When we think about venomotor tone, we're thinking about bit more smooth muscle. We're thinking about kind of like tension in the walls of veins, and we're thinking about this concept of compliance. Okay. So we left off and we identified this venomotor tone as the kind of baseline state of tension in the walls of the veins, which do have a little bit of smooth muscle. That smooth muscle has alpha adrenergic receptors, which we talked about when we talked about arterioles. Those are the ones that are going to respond to norepinephrine by causing constriction. So when they get triggered, when we increase venomotor tone, we're saying we're making the walls of the veins like a little more stiff. They're going to behave a little more like an artery. And we know that the arteries have higher pressure. So this is going to be changing that kind of pressure and resistance in the veins. All right. So we're going to walk through a flow of how we put this all together to affect the heart, basically, and therefore also our mean arterial pressure, which is what we're getting to. That's disappeared. So annoying. Okay. Anyway, we'll step through it piece by piece here. Okay. So this last part that we've been talking about, we're talking about really something that your nervous system can affect, right? That's a way in which the venomotor tone is different. So the venomotor tone and that smooth muscle is responding to sympathetic nerves, so kind of extrinsic control from elsewhere in the body. So when we see this increase in venomotor tone, so like increased kind of tension in those walls, this creates a drop in venous compliance. And we're remembering that graph of compliance, right? So arteries have that low line, low venous compliance. It's more like an artery. High compliance is like a loose baggy vein. So when we drop down our venous compliance, that's saying the same thing, right? We have this relationship where just a little bit of volume is going to create more pressure, like we would see in an artery, versus our usual situation with veins. Okay. Right. So we do have other things that are affecting our venous pressure. So one thing that affects that venous pressure is this decrease in compliance due to increases in venomotor tone. But we know that our skeletal muscle pump also increases that venous pressure. We know that our respiratory pump increases venous pressure in the abdomen when you're breathing in, and then in the thorax when you're breathing out. And we have increases in blood volume that can potentially affect our venous pressure as well. Right? So usually when we think about blood volume, we're thinking long-term, we're thinking kidneys rather than moment to moment. But this also would have an effect on that venous pressure. We'll see a kind of interplay between kidney function and heart function if you go on to think about medicine in more detail in those systems in the future. Kind of beyond the scope of this course at this point, though. Okay, so we've gotten to ways we can increase our venous pressure. Okay. Venous pressure increases venous return, right? Because venous return, returning blood to the heart, is all about now a pressure gradient between a vein and pressure in the atria. So since we're thinking systemic circuit, we're thinking right atrium. Eventually you will see in lab those big veins going to the right atrium. You'll see our superior vena cava, our inferior vena cava, all coming back to that right atrium. So across the systemic circuit, across the blood vessels, we want high pressure in the aorta. We want lower pressure in the vena cava coming back to the heart. But at the moment that we're trying to fill the heart, we want to make sure that we have some pressure there in the veins so that we have a pressure gradient helping the heart to fill. So when we have these increases in venous pressure, this helps us increase that venous return. And as we fill that heart with blood, as we see that blood move into the right atrium, as you fill it up with more volume of blood coming from those veins, that increases the pressure in the atrium. And from our study of the heart last semester, we can have an idea of why that's important, right? But a quick reminder, when we increase the pressure in the atrium, one of the things we might say that we're increasing here would be our end diastolic pressure or our preload, right? So if we were to measure pressure in the atrium, the end of diastole, so the end of that relaxation phase, the end of the filling, right? If you're putting more blood back in the atrium, getting higher atrial pressures there, you're going to see higher pressure, higher preload at the end of diastole. And the effect of this, right? We have this higher end diastolic volume going along with that higher end diastolic pressure. Was one of the ways that we could affect our stroke volume, right? So we thought about it from the perspective of the heart back in December, right? If you fill with more blood at the end of diastole, at the end of filling, you have this higher pressure, higher volume. That means as the heart contracts, right, as you squeeze, we actually have the situation where you end up ejecting more blood with this higher stroke volume. Part of that hopefully seems intuitive, more blood squeezing more out, but we also know that part of that has to do with the stretch of those cardiac muscle fibers. We know that stretching out those cardiac muscle fibers a little bit actually puts them closer to their optimal length. So we have more cross-bridge cycling, contraction is a bit harder. So when we're tracing through all this, where we're going is that we're going to start thinking about how this ultimately affects blood pressure, right? So we know that stroke volume is one of the two things that affects our cardiac output. We have to have our stroke volume, so amount of blood per heartbeat. Then we have to have our heart rate, how many beats per minute. That's how we get to cardiac output. And as we're going to be thinking about today, we're going to be thinking about mean arterial pressure, so that kind of weighted average blood pressure, as being something that changes really in response to cardiac output. So we're going to be reshaping that flow equation. We know we have this relationship between flow, our cardiac output, our mean arterial pressure. So really driving that pressure gradient and total peripheral resistance. We've thought about it before as how do we increase flow? How do we decrease flow? But today we're going to be thinking about the fact that really our cardiac output is something we're directly kind of affecting with our venous return. We're directly affecting cardiac output with our nervous system. So really that's one of the things that we're more likely to be kind of changing independently. So we're more often going to think of mean arterial pressure as something that varies in response to these organ systems that are directly affected. Okay, so summary of this whole chart in terms of where we're going is that when we see these changes to the veins, when we see these increases in venomotor tone, we see other increases in venous pressure, ultimately the effect is going to be an increase in your blood pressure, an increase in this mean arterial pressure by way of an increase in cardiac output. Okay. These aren't working, so we'll review that later, right? But basically, our factors increasing our venous return and our cardiac output are those four at the top, right? Our skeletal muscle pump, our respiratory pump, our sympathetic activity, creating this increase in venomotor tone and drop in venous compliance in the veins, as well as potentially an increase in blood volume. Okay. So breaking into our next packet, we're going to be talking about lymph for a very brief amount of time before we talk about our regulation of mean arterial pressure, of MAP in and of itself. All right. So for now, we want to know our lymphatic system exists, right? We mentioned it here and there when we talk very briefly about our types of blood cells, and we talk about especially white blood cells. We may know from our daily lives that the lymphatic system is tied up with immune function. So this is one of the places that you're going to see immune cells, white blood cells like our macrophages, encountering and responding to pathogens. But we also know that the lymphatic system has other roles to play, right? So last time we were talking about our net filtration pressure, right? So that action in the capillaries, where we're balancing out our fluid compartments. In particular, we're balancing out our extracellular fluid. So balancing the fluid in the bloodstream relative to the fluid in that interstitial space, right? So moving some fluid towards the tissue. And we know that on a daily basis on net, we're actually moving about 3 liters of extra fluid into that interstitial space. You don't want to end up just a big swollen circle person with no blood left in your veins and arteries, right? So this is why we need our lymphatic system here as we discuss our cardiovascular stuff. So if you see the lymphatic system in the body, it may look a little familiar from a physiological basis. It really works a lot like the veins. So it's going to have systems of vessels. Those vessels are going to run kind of parallel to other blood vessels in the body. And like the veins, it's returning fluid ultimately to the heart. So this is going to be an open system running kind of parallel to your capillaries. And ultimately, it dumps back into a slightly larger vessel called the thoracic duct, which sends that fluid back to the right atrium. So we're going to see this connection of this lymphatic system to our cardiovascular system as we get to the heart. So that's how this fluid gets back into your heart and back into circulation so that you don't have this drop over the course of the day in your blood volume. There are a couple things that are different here in our lymphatic system, right? So we do have lymphatic nodes and lymphatic organs in and of themselves, so partially to do with other functions of the lymphatic system, like their immune function. And we think about the flow, though, through this lymphatic system, we're going to see basically, we're going to see valves. We're going to see this parallel system relative to the rest of our circulatory system. So if you see the lymphatic system in a book, this is typically colored in green, right? Typically, we see our arteries in red. Typically, we see our veins in blue. And now we can add on our lymphatic vessels in green. So here we see what our lymphatic capillaries look like. So you can see we have this lymphatic capillary bed right next to our normal systemic circuit capillary bed. So it's got these open ends ready to catch excess filtrate through those lymphatic capillaries. We will briefly mention the lymphatic system and these lymphatic capillaries again when we get to the GI tract and the sort of digestive system, because we're going to see that the lymphatic system also has a role to play when we think about like our absorption of fats, actually. You don't need to know that now. That's just a tidbit. I like to try to make the lymphatic system slightly more exciting than it is in your book, because when you're doing patient care, lymphatics are really important. When you take an A&P course, it's kind of like an aside that we brush into the corner with a broom. So try to have a little bit of excitement about this for the future. All right, so here we see our lymphatic capillaries. Here we see what we think of as almost lymphatic veins going to our lymph nodes. You can see those kind of throughout. Right, so we have a lymph node there, we have a lymph node there. So you have specific clusters of lymph nodes throughout your body. And here we see that lymph flowing back up towards the heart. So here we can see also that as it does that, like the veins, we've got valves allowing us to move that lymph in this unidirectional flow, fight gravity so that we return to the heart. So like the veins, these aren't under particularly high pressure usually. So we need these valves. And here we see how we're coming back to the atrium. So the direct connection is actually not to the heart itself, it's to the veins right before they dump back into your heart. I think the thoracic duct that was mentioned on the previous slide as being like larger, it's probably the only lymphatic vessel that you're actually going to see in lab. It's the only one that we don't kind of like rip out so that they don't confuse you. Most of our lymphatic capillaries and our lymphatic vessels are really small, and they're so small that they tend to look like tiny nerves. So they'd be confusing if we left them for you. But the thoracic duct will be there. And when we say large for a lymphatic vessel, that's going to mean like kind of like a large piece of string. So hopefully you'll be able to see those. Hopefully they don't get too torn by the time of your lab. They're visible right now, so stay tuned. Okay, So that's what we want to know about lymph for right now. Lymph moves in this parallel system to our other vasculature. It's got valves like the veins. It's returning this excess filtered fluid back to the heart so that we maintain our blood volume and we don't lose that excess filtrate into our tissue over the course of the day. Okay, so now we're moving back to map this mean arterial pressure. So we're going to be thinking about changes to mean arterial pressure. We know that changes to blood pressure are something that you're measuring in the doctor's office all the time, right? They probably take your blood pressure every time you have any kind of appointment. So now we're thinking about what's going into that, right? So this is a sort of reshaping of our flow equation that we've done before, and we'll see it again on another slide. But when we think about what can affect our mean arterial pressure, we're going to be thinking about our cardiac output. We're going to make sure that we break it down into its component parts because we know that these different parts of cardiac output, these different factors that influence cardiac output, have slightly different interactions with the rest of the body, by which I mean we know that the sympathetic nervous system can affect both our heart rate and our stroke volume. But we know that if we were thinking about slowing down our heart, slowing down cardiac output, we'd be working with the parasympathetic nervous system, and it can only control the heart rate. It can't do stroke volume. So that's why we want to pay attention to both of these factors. And we now know from our discussion of flow and pressures in this unit that we also have to think about resistance. So we're going to have our total peripheral resistance also as a determinant of our mean arterial pressure. Okay. And just a heads up, right? When we look at these, it's pretty simple, right? Like each of these three factors, if any of them increase, it's going to increase your mean arterial pressure. Because all of them can be affected by the sympathetic nervous system, and all of them would increase in response to the sympathetic nervous system, right? We're going to see a lot of kind of rising tide lifts all boats situation when we think especially about rises in mean arterial pressure. Usually we're worried about the blood pressure getting too high rather than too low. So that's just a hot tip from me. In terms of overall what regulates mean arterial pressure, it's not just the sympathetic nervous system that we would be paying attention to. And so we have neural control of mean arterial pressure. We're also going to have hormonal control. And we also want to know something about the systems that help these reactions kind of take place. So we're going to be thinking about this structure called a baroreceptor. So a baroreceptor is a pressure receptor. So like if you've ever seen a barometer, kind of like a thermometer, right? Those are things you can buy. I think they keep them on boats. I don't know anything about boats. That's not true. Weather stations would have them too for pressure. Your body has baroreceptors as well. So when we're thinking about mean arterial pressure, in particular, the baroreceptors we'd be looking at are low pressure ones. And we sometimes think of them as actually volume receptors, even though physically what they'd be reacting to is pressure. Okay. All right. So to understand how we are regulating our mean arterial pressure and how we're thinking about this, we want to return to our understanding of the aorta, right? So when we think about the aorta, we know it's coming out of that left ventricle, right? So this is where during ventricular ejection, all of our blood being ejected from the heart is going. We know that at the beginning of the aorta, we have that semilunar valve, the aortic valve, stopping backflow back to the heart. So our flow should always be moving forward. So here at the top, we're looking at that cardiac output, that flow into the aorta. And here we're seeing a situation where we're at a constant mean arterial pressure, right? So we're just going through the aorta in its normal shape, and we're having this kind of constant flow out to our systemic organs. Okay. But that mean arterial pressure is not always constant, right? We do see changes to it. One of the big ways we're changing it, the most kind of direct change, are increases in cardiac output, whether that's because of our heart rate or a stroke volume or both going up. So when we see these increases in cardiac output, right, just like when we're thinking about how the aorta is maintaining pressure between our different phases of the cardiac cycle, right? During systole, during diastole, we know that more cardiac output pushes out on the walls of the aorta, right? So what this is an increase in the pressure in the aorta. So if this were happening long-term, instead of just as your heart is beating, like in between each beat, right? We would see this as an increase in that overall mean arterial pressure rather than just a kind of moment-to-moment increase here in the aorta. So here we see this increase in volume of blood in the aorta and therefore an increase in that mean arterial pressure. In the case that right here in this diagram, we're not changing our resistance at all, right? So cardiac output could independently increase your mean arterial pressure even without the total peripheral resistance changing. Okay. Here we are looking again at an increase in mean arterial pressure. What we're focusing in on is that the mean arterial pressure in figure B on the previous slide was responding to changes in cardiac output on its own. Here we can see that we'd also see an increase in mean arterial pressure, even if our cardiac output doesn't change, if we squeeze down the pipes that leave the aorta, right? So if you increase your total peripheral resistance, right, this is also going to end up increasing that mean arterial pressure, even if our cardiac output didn't change, because we've got like this backup of blood essentially in the aorta. It's got to go somewhere, so it presses out on the walls, increasing the pressure in the aorta and therefore increasing our overall mean arterial pressure. So this is just another fancy way of saying that that mean arterial pressure would increase whether we have cardiac output going up or whether we have total peripheral resistance going up, right? Both of these or either of these would increase mean arterial pressure. Okay. All right. So we're controlling our mean arterial pressure and regulating it by controlling the heart, stroke volume, heart rate, and controlling our total peripheral resistance, which we know is mostly coming from the arterioles. We got like 60% of our resistance in the arterioles, but also comes from veins. So like things like our venomotor tone that we just talked about would also have a tendency to increase that total peripheral resistance, right? So when we control the radius of our blood vessels, particularly our arterioles, they're the ones that are most changeable, most likely to change, we can change our mean arterial pressure. So we know that we can do that through our neural control. So when we're thinking sympathetic nervous system particularly, we can do that through hormonal control. The hormone that we've most thought about related to the arterioles was epinephrine, pretty directly linked into the sympathetic nervous system because of the relationship of the sympathetic nervous system to the adrenal medulla that produces that epinephrine. But worth noting that it acts as a hormone, and there are some other hormones that play a role here too. Okay. All right. So again, reminder, our mean arterial pressure is that driving force for the blood flow, right? So we're going to be changing it by changing our cardiac output and our total peripheral resistance, but we don't want it to go too high or too low because this is going to affect your overall body's function, right? Keeping that mean arterial pressure in a regulated range is important. This is part of why we're paying attention to, okay, what makes it go up, what makes it go down, right? So you want your mean arterial pressure to stay pretty consistent so that you have consistent blood flow, so that you have enough blood flow, but not too much going to your organs. If we have significantly out of that range pressure, we've got words for it, right? And we got specific problems associated with it. So if you have a mean arterial pressure that's way too low, lower than normal, we name it hypotension, right? So hypo, low, tension is referring to that pressure. So too low of a pressure is our hypotension. And this hopefully is pretty obvious why this would be a problem, right? But you want to think about that mean arterial pressure as our driver of flow to the systemic circuit, to our organs. If you don't have enough flow, you don't have enough oxygen, you don't have enough glucose, and you don't have enough like waste disposal here, right? So in that video on the first day of class, we saw our patient with Parkinson's and a certain type of hypotension who was falling and stumbling when he gets up, right? This would be a result of really inadequate blood flow to tissue. And in that case, right, we're thinking about inadequate blood flow to the vein, right? So this might also be why you get dizzy sometimes when you stand up or your vision goes a little bit gray. Usually not a sign that you have Parkinson's or some other terrifying disease. A little bit of this very briefly can be somewhat normal, does probably mean your blood pressure is a little bit on the low side, not necessarily way too low. But what you're feeling there is that you temporarily don't have enough pressure in the blood going to your brain, maybe in the blood going to your eyes, things like that. Okay, so that's kind of immediately noticeable to you, probably. Not always so noticeable if your blood pressure is too high. If your mean arterial pressure is way above normal, this is still a problem, but this is more of a long-term problem for your body. So hypertension, hyper for high, tension again for this pressure. It's how we describe a mean arterial pressure that is above our normal range. And in the moment, if it's just spiking now and then, you're probably not going to notice it. If it's linked up to changes in your sympathetic nervous system or something, you might feel something because that nervous system has pretty broad effects on other parts of your body as well. But the blood pressure itself, probably not very tangible to you consciously. But it is a big stressor on your heart and blood vessels, right? So if you have a lot of extra pressure in the system, a lot of extra pressure as your heart is trying to pump out blood into the aorta, right? Because that's where we're thinking of that mean arterial pressure is coming from, right? This is really a descriptor of the average pressure in the aorta. That means your heart is working hard to pump against that pressure. Right? It's also a strain on your blood vessels because the walls of those blood vessels have to withstand this pressure. So if they're always under really high pressure, they can experience some damage, right? And you've got blood vessels through all your organs, right? So this can have more downstream effects to other organ systems as well, as we see effects on the blood vessels going to those organs, the blood vessels within those organs. So this is why you keep a check on your blood pressure throughout your life, but especially as you get older. This is a problem that tends to crop up in middle age or so and going up, that you see these rises over time in mean arterial pressure, rises over time in blood pressure. You want to keep an eye on them so that you don't end up with kind of long-term organ damage. So we regulate our mean arterial pressure because we want our blood flow consistent. And we don't want our heart especially to have to work too hard to get blood out to the body. Okay. So the good thing is, in the short term, we do have regulatory systems that can come into action in the span of seconds to minutes, let's say. And this is going to be coming mainly from your nervous system, this regulation. So this is going to be under neural control. And this is what should be happening as you say, like, stand up, right? So as we're trying to regulate blood pressure, as gravity starts to pull on your blood, right, we should see this short-term regulation kicking in. So we're going to see our nerves affecting our cardiac output, affecting our total peripheral resistance pretty quickly. So heart for cardiac output is our kind of effector organ here. Blood vessels are our effector organ for the total peripheral resistance here. In the long term, right, if we're thinking about long-term changes to our mean arterial pressure, this is primarily the role of your kidneys. The kidneys, when we get there, we'll see are responsible for keeping your blood volume in an appropriate range. And we know that we have this kind of inextricable link between volume and pressure, which we measure through things like compliance, but come back in all kind of ways, right? So by changing your blood volume, increasing it or decreasing it, you would see a long-term change to blood pressure, up if you have more blood in your blood volume, down if you have less, okay? Because this involves the kidneys, this is usually going to be mostly under hormonal control. The kidneys have a bunch of hormones that help them figure out how they should be adjusting how much sort of water you're keeping in your blood. It takes maybe minutes, but maybe days. Good. Right. So we're going to think about this neural piece first. So we're thinking about the short-term regulation first. The short-term regulation is really what we're going to be concentrating on here in this unit because we haven't gotten to the kidneys yet. So when we get to the renal system, we want to kind of keep this in mind, how that's going to play a role back in our cardiovascular system. Okay, so for our nerves. Primarily, when we think about this short-term regulation, we're going to be thinking about negative feedback loops, right? Adjusting these short-term changes in the mean arterial pressure. And we're going to be thinking about this as a homeostatic mechanism, right? This is something that you're regulating through homeostasis. You want it to stay constant. So we got all the pieces of a homeostatic mechanism, right? So we got a detector, we got an integration center, we've got some controllers, and we got some effector organs here. Okay. So what we're going to use to sense changes in blood pressure are those baroreceptors, so pressure receptors. In particular, these low pressure volume receptors. Okay. For our integration center, all of those baroreceptors are talking to your brain. We have a bunch of cardiovascular centers embedded in the brainstem that are processing this information. So then we have to send our signal out from those cardiovascular centers to make our adjustment. So this is going to go out through the autonomic nervous system. So technically, autonomic nervous system is both parasympathetic and sympathetic branches. We can predict already that this is largely going to be our sympathetic nervous system, right? But autonomics overall. And our effector organs are going to be our heart and our blood vessels, because we're trying to affect cardiac output with the heart, total peripheral resistance with those blood vessels. Okay. So here's a look at some of the places you would see these baroreceptors, these pressure receptors. Okay. Sometimes we also call them stretch receptors. Okay. You're going to see the way that they respond is really to sense pressure, right? They're going to be embedded in vessel walls. When there's more pressure, less pressure, it changes how stretched out a blood vessel is. And that's kind of the trigger for these baroreceptors to send a signal that something's changing. Okay. So here we can see that we have a pressure receptor in the aortic arch. So this is one of our arterial baroreceptors. The other places you'll see them, and I think you'll see these starting next week. You won't physically see the baroreceptor, but you'll see its location is in a place called the carotid sinus. So we have our carotid arteries coming up from the aorta going into your neck, and they split before we send one of them, that internal carotid, up into your brain. And in that split point, they kind of puff out. That's our carotid sinus. And that's where we find our arterial baroreceptors as well. Okay. So when we see changes to the pressure, we see changes to the amount that these arteries are stretched out in these locations. And that's how we can tell the brain and then your nerves and send this response back to change that mean arterial pressure. Okay. So in terms of our control centers, they are in a specific spot in the brainstem. So you saw the different parts of our brainstem before when you're looking at like cranial nerves in lab last semester. So specifically, these cardiovascular control centers are on the medulla oblongata. So that kind of gently curving part before you go into the spinal cord. So we got all sorts of stuff going on in there, but this includes an integration center for our blood pressure regulation. Okay. All right. So we're getting this signal from the baroreceptors that our blood pressure is changing. It's going to the medulla oblongata to these cardiovascular control centers. So we're making sense of that signal that we're getting from the baroreceptors. Now we're sending out a response to our cardiovascular effector organs. So really our cardiac muscle in the heart, and then that smooth muscle in the walls of our arterioles and our veins. Okay. So our parasympathetic input has a limited role to play here, but it can play a role, right? So we know that the parasympathetic nerves, and when we're thinking about parasympathetic nerves out in the body, we're really always thinking vagus nerve because it's the only one that leaves your head and neck, right? So our vagus nerve is our parasympathetic innervation out in the body. It goes to the heart. Specifically, it goes to our SA node and our AV node. We know that the SA node, that sinoatrial node, is what's determining our heart rate, right? It's our main pacemaker here. So if we have increases in parasympathetic input, we could decrease the heart rate, which means we could decrease cardiac output, which means we could bring our blood pressure down. We could bring that mean arterial pressure down. More often, we are paying attention to our sympathetic branch of the autonomic nervous system when we're thinking about our short-term regulation of mean arterial pressure. We're going to be in particular thinking about something called the baroreceptor reflex. It'll be up in here in a bit, but usually we're thinking about solving problems like that slight drop in blood pressure when you stand up. So when we're thinking about these increases in mean arterial pressure in response to a low pressure that's not getting us enough flow to the brain and other organs, we're going to get our sympathetic branch of the autonomic nervous system active. So we are also affecting the heart rate because we also have sympathetic innervation to those pacemaker cells in the heart. So both the SA node and the AV node, but the SA node is the one that's really important because that's setting our heart rate. But we can also be affecting a lot of other places in the body working together in different ways to increase our mean arterial pressure, right? So these are our heart rate pieces. We also know that we can affect our stroke volume, right? So our stroke volume can go up in response to sympathetic input because that sympathetic innervation does actually go to the ventricular myocardium, so to the walls of the ventricles, increasing how hard they contract. And when they contract harder, you squeeze out more blood, stroke volume goes up. Okay. Finally, we can affect our total peripheral resistance with our sympathetic input as well, right? So our TPR, mainly with the arterioles here, but also a little bit with the veins. So we have the alpha receptors in particular when we're thinking about increases in total peripheral resistance, because those alpha receptors in response to norepinephrine from the sympathetic nervous system contract, right? So we see vasoconstriction in the arterioles, or we see increases in venomotor tone in the veins. So TPR goes up. The veins would also kind of loop back up to affect the stroke volume as well, because when we increase that venomotor tone, as we just spoke about at the beginning of class, we've got this whole cascade of effects that ultimately returns more blood to the heart. And when we see these increases in venous return to the heart, we also increase our cardiac output because of that interplay between that venous return, how full the heart gets, that end diastolic volume, and how that slightly stretched out cardiac muscle responds. Okay. So here we see a reminder of those connections, right? So we talked before about the relationship to the heart. So here in blue, we see that parasympathetic pathway. So we're looking from a cardiovascular control center. Here we see the vagus nerve actually coming out of the medulla oblongata, right? And here we see the connection to the SA node here in the heart, okay? So that's our heart rate piece. Could slow it down, could decrease your blood pressure. If you're relaxed, your blood pressure hopefully goes down. And they do tell you to try to relax as they're measuring your blood pressure for a reason, right? But we also have this sympathetic nervous pathway. So we have a connection between the medulla oblongata and the spinal cord that's important here. So just a reminder of autonomic nervous system stuff. Parasympathetic roots start from your head and from your sacrum. So this craniosacral origin to those nerves, always from the top or the bottom. Our sympathetic nerves come only from the thoracic and start of the lumbar region. So that's why you see this purple nerve going down to the spinal cord, because the actual sympathetic nerves are coming out of that thoracic region. You're actually going to see the sympathetic chain or the sympathetic trunk in lab again starting next week. So you can keep a peek out for this structure and appreciate it, right? But we'll have these nerves going into the sympathetic chain and heading out to the SA node, to the ventricular myocardium. So we're doing both heart rate and stroke volume there, but also branches going to our arterioles and our veins, changing the smooth muscle state, changing total peripheral resistance. Okay. So next time we'll talk about the baroreceptor reflex itself because it's important, so it has a special name. But those are really the fundamental basics of mean arterial pressure.